So, hello everyone. Today, Dr. Chitra Selvan and I are going to speak about how language matters in diabetes care. However, before we start talking actually about language, there's something that I would like to talk about first, and that is the state of the healthcare system in India today. And I think that it is undergoing a crisis of distrust. Some of this, what I'm presenting, is taken from a document called Leapfrog to Value, which was written by Chintan Maru and colleagues. This was a white paper which was supported by the Bill and Melinda Gates Foundation as well as the USAID, which talks about healthcare systems in low and middle income countries. I think in India today, most people question government clinics. Day in and day out, you see newspapers writing these exposés on private hospitals. And there's a lot of tertiary hospitals coming out, but there's very little focus on community-based prevention or primary care infrastructure. I think there's a lot of frustration, not only among patients and caregivers, but I think doctors are equally frustrated with the system. And I think we're rapidly approaching what is like a breaking point. The other point I wanted to make is that, as a young doctor, when you come out into practice, you look around you and you want to know who are the successful practitioners. And how do you assess success? Most of the time, what you do is you look around and you look at the doctor who has the most number of patients crowding his outpatient clinic, and you think, oh, that's success. And somehow along the way, you start measuring your own success by the number of patients that you see. I remember this young diabetologist who trains with me and who had trained with me and I had mentored, calling me one day and saying, ma'am, you know what? I'm so excited. I've really made it today. I've seen 50 patients in the clinic. So somewhere along the way, volume-based care is our metric for success. But I think it's time to transition from volume-based healthcare to value-based care. If at all we intend to change the future of healthcare in India. And what do I mean by value-based care? I mean that it is time to focus not only on medical and scientific outcomes, but also focus on outcomes which are important to patients. Now, there are two metrics of measuring value-based care. One is what is patient-reported outcome measures, and one is patient experience of care. So what do you mean by patient-reported outcome measures? Now, if I am a diabetes specialist and I am seeing patients with diabetes and I'm concerned about retinopathy in my patients. So what I will usually do, or what most scientists and researchers will try to measure the incidence of retinopathy, the prevalence of retinopathy, the risk factors of retinopathy, and then try to use this knowledge to help our patients. But to the patient, it probably is not important what is the severity of the diabetic retinopathy, what were his risk factors, because he already has the retinopathy now. What is probably important to the patient is how much functional vision will I have? Will I need visual aids to actually see? What will be my quality of life? So what is a medical and scientifically important outcome may not necessarily be something which is important for the patient. And it is time to take patient-reported outcomes into consideration as well. The other very important thing, which is going to be the future of healthcare, is patient experience of care. So as a doctor, you're focused on making sure that you make the right diagnosis. You tell the patient all about the disease in a scientific way. You tell them all the complications, and then you tell them the pros and cons of treatment and hopefully help the patient make the right decision. However, what matters to the patient is not only all of this, but what is equally important to the patient is the waiting time it took for him to actually get to see you. How the staff behaved with them. Sometimes after doing everything right, the patient may actually go and complain that the doctor didn't even look up at me or didn't even smile at me. So I know that when we train in medical school, nobody talks to us about all of these things, but I think it's time to transition to this value-based care system, because this is the only way that we can truly solve the problem which is ailing our healthcare system. I'm not just talking out of my hat. This was a survey where it was the same clinical consultation. However, if the patient had a good satisfaction with the billing process in the hospital, they were likely to rate the clinical consultation 93%. And if they were not satisfied with the billing experience, they rated the clinical experience, clinical satisfaction only 63%. And to a doctor, it is so beyond comprehension that what relation does my explanation to the patient have with the billing experience? However, this is what is important, because people don't really rate care by the actual objective measures, that was the right diagnosis made, or did the blood sugars come down, was the HbA1c 6.5, but they rate quality of care depending on what they perceive the care has been given. And the care includes the entire experience that the patient has. To come back to doctors, of course, we can't offload all the blame to the billing and the front desk, but the strongest predictor, this is a health consumer assessment of health provider systems, and patients rate provider communication skills very strongly, and this predicts the overall satisfaction that they have with the hospital experience.
So that brings me back, Dr. Tejal, to this quote that we read on Twitter together and discussed. So this one, Dr. Mark Lewis, who's an oncologist, made a very pertinent observation that when we were all training to be doctors in medical school, nobody ever told us that the hardest part of our clinical practice would be just convincing patients or people who come to seek help of our good intentions, that we are not out to, fleece them, hurt them, harm them with our words and with our actions. That kind of ties back to the point that you made about how value-based care probably seems to be the more important thing. But as a practicing clinician in India, I'm wondering that I already have so much of medical knowledge that I took all of my life to learn and so much of my energy to master. And now there is an added skill that is now becoming more and more a prerequisite. I'm just beginning to wonder if there's too much being expected of me.
I don't think so, because Dr. Chitra, if you want to be truly effective, and that is what our intention is ultimately, then this is a skill that you are going to have to master. And I think for people like us who've read Williams Endocrinology page to page, communication skills can't be that difficult, to really learn. But to come back to communication, if you want to break it up and make it simple, then communication primarily consists of two parts. So one is verbal language. But see, verbal language is not just the words, but the tone of voice that you use, the inflection of the voice. Really, you really took care of your diet. So, there is this already this judgment in your tone and your inflection saying that I'm sure you're not telling me the truth. The volume that you use, even non-verbal language, that raised eyebrow of sarcasm, a smile or a frown, sometimes just taking the patient's hand in your own, or a pat on the back when they leave the clinic, nodding when they're talking, so they know that you're actually listening and you're all there, actually turning towards the patient and not looking at your computer screen or looking down at the reports. So I think that communication skills encompass a lot, which is not only words, but the way you use the words as well as the non-verbal cues and everything that we use along with the language.
So I do know that much of all that happens in our clinic, we do attribute to the fact that we are seeing many patients and we don't have enough time. But I'd like to flip that same argument to say, just for the same reason that we spend a short amount of time with our patients, literally every single thing that we say or every single thing that we do could have an impact on our patient and in turn on the outcomes of the exact condition that we want to improve for our patient. So which just means that probably it's time for us to rethink one about our own practice and what we want out of our practice, also what we want from each of the interactions that we have with those persons who come seeking help to our clinics. So we are hoping to probably get you to rethink and go back and introspect and re-audit maybe our process of seeing patients with clinic, because this journey has been truly revolutionary for me and Tejal both. And I speak for Tejal, I know for sure that it has definitely changed the way that we continue to practice, and we've gotten into a mode of introspecting and editing, introspecting, learning from each of those episodes. So now if we could move on to the next section, where we will pause to think about certain commonly encountered clinical scenarios and what our intentions are and what we actually say, but what is perceived by the patient. So Dr. Tejal did make a point about how exactly what is perceived by the patient might be completely different from what we intend to say. So pregnancy in a person who has diabetes is a condition which you and I are encountering very commonly. Also, it is a condition which probably triggers some anxiety in us as healthcare providers as well, because we're concerned for not just the mother and the pregnancy, we're also concerned for the child. We're also concerned about how the uterine milieu during the pregnancy, which we are probably going to play a part in controlling, could affect the child's future prospects of diabetes and metabolic health. And all of this, in some way, makes us maybe hyper anxious around this condition. And sometimes we might sound, we are coming down a little too heavy on our patients. So, this is a particular conversation we had in one of our focus group discussions. And this person is actually herself a healthcare professional. And she recounted her tale of her pregnancy and a diabetes story. So, she was found to have diabetes when she was 8 weeks pregnant. And she was put on this intense basal bolus regimen with intense monitoring of sugars. And she delivered a child, and her child went into respiratory distress and required ICU care. Her endocrinologist, at the end of it, when they were found in the ward with the child, walked up to her, and that was an opportunity to have said so many things, but made a point to say, if you just controlled your sugars a little better during pregnancy, maybe she would have not gone into the ICU, and maybe she would have been
And
better.
this is in spite of having done everything right.
Absolutely. So going the whole length of it, and this was a comment which she still recalls maybe a decade after the pregnancy itself. And this is something else which was recalled by another woman who was there. If you don't control your sugars, your offsprings will get it, and you will get it earlier. That actually scares many women. So she went on to ask, like, do you want another generation to suffer like you? This was something which a doctor said to a patient itself. And another woman went on to say, I decided not to have a child after listening to my doctor scare me. So, having a child is a very primal, very basic instinct for all of us. And I think it's important to understand first how much knowledge your patient already has. So, there are some women who are completely oblivious to the risks that a pregnancy brings in the context of glycemia or diabetes itself. And probably there we might need to present the whole picture. And some of our women already have a background understanding, have understood, have seen a family member go through it, or have read up and caught up on information. So it's primarily important, I feel, to basically assess the level of knowledge they are at, and then complement the language that they have, instead of unloading the whole lot of knowledge that we have about the condition and the context itself. And probably what they're looking for more than all the knowledge is probably just reassurance that we have seen many women go through pregnancy and have healthy babies and go on to lead a healthy life with a healthy family. Probably they want to listen to that story first, even before we go on to harp about the complications and the consequences. So all of those are some things that we need to consider, especially when we're talking about pregnancy. I think this is a topic which is very close to women. We'll now move on to another common condition or a scenario where we have family members who accompany the person with diabetes who's coming to us. And many times people come in with complications. It could be a gangrene or an amputation, or maybe a stroke or a heart attack. And we are meaning well when we want to, let us say, sensitize the family member, maybe the son or the sibling, to maybe get their sugars tested. So potentially avoid another complication as we see it in our end. That's the medical side of us, right? So we did a survey of doctors in which we found that a good percentage of us, up to 87% of us, were having the intention of sensitizing our family members, right? So that's a good thing. But some of the words or sentences that we use is something that we must maybe pause and think about. So this is one sentence which one of our patients recalled in our focus group discussions. Look at your mother. She was hefty, not able to move, and now you will become like that unless you take care. That was one of the scare tactics which was used by the doctor to sensitize the son. This is a hereditary disease and you are going to have it, so will your children. That sounds so definitive, almost like a death sentence. The age at which your father got diabetes, the same age you're going to get it, or maybe even younger. That's almost, again, scary itself. So we all understand that type 2 diabetes is a heritable condition, but it's probably important to understand that it's not just genetics when it comes to transmissibility of type 2 diabetes. There's a very good component of environment which plays a role, and shared behaviors which we all do as family, which are potentially modifiable. So when we talk about risk of inheriting type 2 diabetes in a family member, it's not inevitable, right? So maybe we should move the conversation to, next slide, the risk and about how it is preventable A good percentage of type 2 diabetes in family members can be prevented. Maybe we should talk about prevention rather than the inevitability of getting type 2 diabetes itself. So assess the risk and not the inevitability. Talk about the possibility of delaying diabetes. Of course, talk about the necessity to screen and keep a check on it. But essentially, talk about hope rather than taking away hope. Uh, Moving on to another common scenario, one of our patients went on to tell us that if you're going to warn me about diabetes, if one of my family member has diabetes, probably some of the words that you should use are, uh, you are educated. Times today are much better. We have so much of advancement when it comes to medications. We've learned so much about management of diabetes better. And maybe we are also meeting each other much earlier, right? So we do have an opportunity to change the arc of how diabetes might pan out in you, even if you have diabetes. This context is completely presenting hope as an option instead of taking all hope away around diabetes. Now, I invite Dr. Tejal to speak about two other situations, probably potentially difficult ones, and what patients perceive from the conversations we have in our clinic.
Right, Chitra. But before I just go on to that, I just want to say that this patient who we are talking about still follows up with me. And the Language Matters document that we brought out, I actually mailed it to him for him to read and to go through it. And he wrote back in a mail telling me that he never thought that in his lifetime, a doctor would ask him what he thought about the care that he was being given. You understand? So I think it's really time to give patients a seat at the table, understand their lived experiences, and maybe modify the way we communicate a little bit. So I'll just take very common scenarios explaining the risk of complications. So I think that when a patient sits in front of us with diabetes, somehow we forget this individual patient and we just have a quick flashback of all the complications that we've seen with diabetes in the hospital with an HbA1c of 10 to 12%. You know, you remember the worst gangrene or the worst retinopathy. And somehow we forget the patient who's sitting in front of us. That doesn't mean that I'm a bad doctor or I'm not a good person. But what it means is that sometimes we need to put aside all of our past experience and just look at the person in front of us. And one of the common scenarios is, telling a patient about their risk of diabetes. And when we open our mouth, we usually come up with words like this. So this is actually a survey which was done in healthcare workers, and we asked them to note down all the words that they commonly use to explain to patients about the risk of complications. And words like death, amputation, heart attack, dialysis, blindness, failure, damage, lack of motivation. So all of these words can be very damning for that individual person sitting in front of us. And what we'll usually say is, you know what, if you don't control your sugars, you will get a heart attack, or you may become blind, or you may lose a limb, or you will have failed kidneys. Now, what happens when you do that is you take away all hope. And one of our patients very smartly told us, that the patient knows that he has to face a dismal future. He knows that. But instead of creating a fear psychosis, if you could create some positive energy in us, it gives us more of a sense of control over our condition. And we feel motivated to do something about it instead of making us really fearful of what the future holds for us. So what you could do is, instead of saying what will happen, you could talk about what you can avoid. So you could simply say that if you manage your sugars better, or if you manage your sugars well, you can live a life which is free of the unwanted consequences of diabetes. You can keep your heart, your kidneys, your eyes completely safe. So that could be just flipping it and looking at it at a slightly different way, but giving hope, not taking it away. So what we need to understand is that fear more often leads to paralysis and not motivation. Yes, we all remember that one patient who we'd really scolded and next time came back with an HbA1c of 7%. But this doesn't hold true for 90% of the population. It holds true just for 10% of the population, and we can't scare 90% for that 10%. Other, I think, really big demon in every practicing physician's mind is initiating insulin. And this somehow, I feel, very honestly, Chitra, is more stressful for the doctor than it is even for the patient. Because you're just in your mind thinking, oh my God, now I have to talk about insulin. And now the patient will ask me all those cliched questions about insulin being bad for him. And somehow we become defensive right at the outset. So one of our patients, this again is a nutritionist who still following up with me. She says many doctors use insulin as a weapon to warn you that, look, if you don't control, I'll put you on insulin. Now, what this implies is that the person is not bothered about their health, is not doing enough. Now, for somebody who has diabetes for 15, 20 years, in spite of doing everything right, they still may not be able to manage their blood sugars well. And that is because of insulin deficiency. And I think sometimes you, instead of using it as a threat, we need to kind of start talking about insulin a little bit earlier than right at the last minute and then using it as a threat. This is a story which is very close to my heart because this patient, she was part of our focus group discussion. She'd seen me in clinic and we recorded her in February of 2020. And LV was an animal activist and she had been explained by one of the doctors that, your pancreas is like a dead horse. And she was horrified, being an animal activist herself, that somebody could use an animal, that to a dead one, to explain about something in her own body. And she felt this was completely not a nice way to communicate. Unfortunately, we lost her in August of 2020, and her son actually called me up to tell me again of she felt that there was hope in her lifetime when doctors were actually bothering to find out what they experienced, and doctors cared about the way they made patients feel. And I hope I can make her happy. I did share the document with her as well, though it was not completed by then. So I think we need to avoid using insulin as a threat. Don't use abstract analogies about horses and milking cows. To you, it may make sense, but to the opposite person, it doesn't make sense most of the time. And I think most importantly, not blaming or shaming the patient that, oh, you didn't take care of yourself, that's why you need insulin now. I think that's not done. What you could do is start talking about insulin early. So you know this patient's HbA1c is creeping up. Start talking about insulin, that you may need insulin in future. Use scientific terminology, use charts, use graphs, keep them handy in your clinic so you could show them what you want to talk about. And please really emphasize that it's not their fault, and tell them that I know you're doing everything right. And yes, there are patients who do everything right. Not everybody is a non-compliant or a non-adherent patient. So acknowledge that they're doing everything right, but they need insulin to kind of support their body. And this insulin will help them to lead a healthy life, probably free of complications. Back to you, Chitra, if there was anything else. Oh, yeah, Chitra. So, Dr. Chitra and I, this we always talk about that, when people listen to our talk, they'll think, oh, you just asked the patients, but you didn't ask the doctors what they felt. So, Chitra will tell you a little bit about what doctors felt.
Yes. So after we went through the transcripts of all the focus group discussions, and let me remind the audience that these were patients from our clinics whom we thought loved us, and they were so happy with our treatment, and they even indulged us by coming in physically for a focus group discussion, probably just at the brink of the pandemic. So that's how much they loved us. Okay. And yet there was so much of angst and hurt and pain in all of the words that they told us, thinking that what is it that we're missing? What are the doctors doing? And how can we tell the story without ever understanding the doctor side of the story? So to complete the picture, we went ahead and designed a survey which we administered online, which included around 900 clinicians who were predominantly treating individuals with diabetes. We had both quantitative and qualitative questions, and we used the mixed method of analyses to understand the findings better. Up to 69% of the participants were men with a mean age of 45 years. Up to 37% were individuals who had an MD medicine degree, a good percentage had DM endocrinology, and a very good percentage were general practitioners. Of course, up to 80% of them were practicing in the urban setting, with 35% in private hospitals. Everybody did say that the length of consultation for new patients was about 11 to 20 minutes. Up to 58% of them said that. And for follow-up was about 6 to 10 minutes. This is something that all patients did speak about. So if you want to quickly audit, maybe you should audit your own practice, right? But what was questions important? Language, your eyebrows, where you're looking, whether you're using your phone is important. Yes, all of that is extremely important during a patient consult. So we know that it's not like the doctors are not aware. It's not like the doctors don't care, right? Yet when we asked doctors to reflect about their practice, some key points which came out was uh, up to 50% of people were greeting individuals as they came in, but they did acknowledge that many times they were attending phone calls in the middle of consultations, which essentially meant you're disengaging from the person sitting opposite you. And also, a good 50% of us were getting irritated when people asked questions and again and again. And that was a common thing which came out from the doctors' conversations, that इतने सारे questions पूछते हैं कि yes, मैं तंग हो जाती हूँ. So although we are aware that communication is crucial and important, there are some things in our practice which probably, due to whatever reasons, are still happening. And if you're asking me why should I think about this, my patients are coming. I have a busy roaring practice. Maybe Dr. Tejal and Dr. Chitra don't have enough patients, and that's why they're doing this. But this has been a year where we're all looking at ourselves, our own health, our own lives. We've had time to reflect after many, many decades of running around. And it's important to understand that words have power. They do things, they change things, not just to the person who's listening to you, but also to the speaker. They feed understanding, yes, but they also feed emotion back and forth, and they amplify it. So, to put it simply, if I am being angry, yelling, using harsh words every day through my busy practice with my patients every day, I would think that it would have an effect on my health, on my mood, on my well being as well. So, in that, at least there is an ulterior motive for us to want doctors to maybe focus on the words that we use in clinical practice. All of this, all our learnings, the doctor survey stories being written up as a paper, much of the learnings from our conversations with patients have all been condensed into a beautiful document called Language Matters, Type 2 Diabetes, Mellitus in India. And this has now been hosted on many international platforms. We also have endorsement and a forward from the president of RSSDI and the Endocrine Society of India, and is a document which is very, very close to our hearts. It's easily available on the net. If you just go to Google and type Language Matters, you should quickly have a quick reading, and there might be some interesting insights in there.
Chitra, so if I just will read the last, two lines that we've written in the Language Matters forward, that this document is not meant to blame or judge healthcare professionals. It is only meant for introspection and reflection on how we can communicate our intentions in a better way to make the experience of the condition more positive for patients. So no blame, no shame, just that what we ultimately became doctors for, to provide comfort, care, and improve outcomes. We just need to continue to do that, maybe in a slightly different way. And before we close, a very big special thank you to Dr. Unikrishnan. Most of the times topics like this are not included in large conferences, and Dr. Unikrishnan has an amazing conference which is really well attended, and we're so glad that he gave us this opportunity to showcase our work. And we just want to close with the saying that unexpected kindness is the most powerful, least costly, and the most underrated agent of human change. Thank you so much.
Thank you.